What are the hormones that change?
First thing that happens is ovulation goes a bit here and there. As you mentioned, you said what hormones happen. So, if you look at a typical cycle, we are looking at the first half being dominated mainly by estrogen, and then there being some ovulation. Let's say in a typical 28-day cycle, day 14 is when a woman will ovulate, and then progesterone takes over in the second half. Of course, there is still some estrogen there. It's basically preparing a woman for pregnancy. The lack of the rise and fall of progesterone makes her not get her period.
And could you also tell us what happens as a result of that hormone declining?
So, for a woman, this means she may start facing irregular cycles. So, she may notice that her cycles were earlier 28 days, now they're every 21 days or every 22 days. So, these are very subtle early signs that she is coming towards the end of her reproductive phase.
Menopause. It was this all along. Most women in India wouldn't have heard of HRT, and those who have will have been told to be afraid of it. So today's episode is a conversation about what is actually happening inside a woman's body during menopause, what HRT is and what it does, and what Indian women specifically need to know. My guest is Dr. Sukhpreet Patel. She is an obstetrician and gynecologist with over 25 years in women's health, MD, OBGYN from India, MPH from the UK, and a registered health and nutrition counselor in Canada. She ran one of Mumbai's well-known IVF practices for nearly 2 decades, then closed that chapter to dedicate her practice entirely to menopause. She is the founder of Menopause Wise. She's also, in her own words, a post-menopausal woman. She has lived through what she now treats. Welcome aboard. It's a pleasure to have you on our show.
Thank you so much, Roshini, for doing this and for having me.
I want to sort of just quickly pick up. You spent 2 decades working in and running an IVF clinic, and you have now closed that chapter and moved entirely into menopause, and supporting menopause women, patients going through this life stage. Was there a mere moment, a patient, or something that triggered that?
Well, I think it wasn't a moment. It was pretty gradual. My understanding of how important lifestyle was started creeping in once I hit 40, and that changed the way I approached IVF. And it made me want to study public health and work in public health, and that's how my master's in public health came in. And after that, public health, my own menopause, different women asking me about what to do about menopause. I think it was a collective. There was a very gradual shift in my thinking that it wasn't an individual problem, it was a public health problem. And
Hmm.
we need to look at it as a population and as an individual. But besides that, that it wasn't going to be um, one thing that was going to work. We are going to have to work with multiple tools to really live healthy beyond perimenopause and menopause. So didn't happen overnight for sure.
So when did you actually start? When I know you are setting up a clinic, can you tell me what the name of that clinic is? I know you're setting it up in India. I
Mhm.
would love to know what the name is. I'd also love to know if there are how many clinics are there, such as the one that you are setting up, just to put
Well,
context to this.
I think the important thing to look here is not really a clinic, is to look at a resource that provides information, because 90% of the job is done if one just has the correct sort of information. If women are well informed, they don't need to go to a doctor to really figure that bit out, especially their
Hmm.
lifestyle. They can do their bit sitting at home. So I don't like to call it a clinic because it sounds like a place where sick people go. But I think I want to look at it as a set of resources. One of them is meeting a doctor. It doesn't have to be a gynecologist, but one of them is meeting a doctor. But the remaining resources need to be tapped into. And I feel again, one doesn't need a dedicated clinic towards it. It was just my dream to create something that allows multiple multidisciplinary care beyond just a doctor. And so that was my dream and my vision, that there needs to be, every woman needs collaborative care, not go for hormones to someone, go for nutrition to someone, and go to go for your bones to someone else, and then nobody's talking to each other. I think that was the dream, was, or the vision still is, collaborative care. It will take a while to build it. I'm very patient with it. I'm not in a hurry, but I feel things are changing. Doctors do want to be better informed about menopause and hormone therapy. We're seeing that wave. So I, I, I don't know if there are other clinics, but I'm very sure there are definitely, over the past decade, we've seen so many women's wellness places, and keen interest from doctors and other providers to help women. So a lot is going on.
Yeah, I think a lot is going on, but I think your approach may be slightly more unique than everyone else's, because you're not looking at it in silos. And you're right, women can go and speak to a gynecologist, but like you said, they may not speak to an endocrinologist, they may not be able to speak to a nutritionist, and it is all linked. So because there is change across your body everywhere, so I think you have a unique perspective in what you are trying to do over here, and I think that we look forward to that.
Thank
When
you.
where is it? So I know you don't want me to use the term clinic, but when does this clinic, because it is a clinic, when does it open and where is it?
Well, we are functional already. We are in Mumbai at Nana Chowk, and um, it's already functional, but it's, I feel it's just part of my dream, and there's so much more work to be done. So and a lot of it happens online as well, right? Online, in the sense, I mean, resources can pass on to a woman online, whether it is if you're looking at her ability to download something, or her ability to follow um, uh, simple videos which are free of cost online. I feel we have to stop looking at it as a brick and mortar, and we have to, in today's day and age, we're recording this online, and I feel
Mhm.
like there are so many resources a woman can access sitting at in her home, which doesn't need a doctor. We have stopped giving the attention to um, all the non-medical, the non-prescription parts of midlife care, and that's equally, if not more important than a prescription. So,
Couldn't agree more with you, but did we ever give non medical care to midlife women? Is the question. I mean, historically, I mean, isn't this just a transition that women have just gone through without much ado about anything, right? It just passes, right? That's kind of, it's been very silent, I think.
well, it has, but also now, if you
Would
look
that
at
be
it
correct?
historically, 100 years ago, average lifespan for women was 52. So, where was she really going through
Hmm.
menopause, and how was she living beyond menopause? She was menstruating, giving birth to children, and then she was dying. And now we are seeing women live up to sometimes even half their life beyond menopause, right? And
Hmm.
that warrants attention now. So, the one thing that we need to, of course, I feel that as women, we were included in research studies very late as 1993, but as you know, as a compulsory, we have to be including women in it. But the point is that we also have to look at evolutionarily, where have we been, and we're only looking at women live 50 years beyond menopause now, in the past few decades. And research takes time. So I think there is a bit of an urgency, a bit of impatience. But if someone tells me, what will happen if I take hormone therapy for 50 years, can you tell me? And 50 years of research will take 50 years. It can't be fast forwarded. So if when
Hmm.
women ask questions like these, how do we answer them? And then there's anger, that why isn't there research? But now let's just go back 100 years. If I have to give you a reply for 20 years, Where is, yeah, so we
Right.
have to really look, put it in perspective, stop being angry about it, and think about what can we really do about it instead of wasting our
Hmm.
resources on anger.
What are the hormones that change when a woman goes through perimenopause and menopause?
Yeah.
What are the sort of the string of hormones? Because it's not just one hormone. Can you can you please name those hormones, and could you also tell us what happens as a result of that hormone declining?
Right. So typically, if we look at perimenopause, it's the common analogy that we hear very often over the internet is that it is adolescence at the other end of the reproductive age group. So, reproductive age group is more or less counted as between 15 and 45. That's when a woman is normally naturally cycling regularly. She has the ability to get pregnant, to give birth. So that's counted as the reproductive age group. If we go before reproductive age group, we are looking at adolescence where hormones are beginning to come in, and then we are looking at perimenopause where hormones are beginning to dwindle out. The important thing here is to visualize it as a transition, just as adolescence was a transition. Puberty is a transition. So basically, it's not, a girl
Mm-hmm.
doesn't become a woman overnight. And similarly, she's not going to become postmenopausal overnight. The ovaries are going to fight it out till, till their very last breath or their very last egg to produce some hormone to protect this woman. And so if we look at it like that, we can then now visualize that, oh, it won't happen overnight. It's going to happen over many years. And so what happens during these years is, from a normal cycling woman, first thing that happens is ovulation goes a bit here and there. And you can we sometimes use the term anovulatory, which means an egg is not formed during that cycle. But what typically happens is that it doesn't mean that the egg is not formed. Sometimes there are ovulatory disorders, so partly formed, not released. The bottom line is, for the woman, it creates menstrual irregularities. So she'll start seeing a shift in her cycle. Sometimes very early, they start to see, I hear women say, oh, my cycles have become shorter now. So it used to be every 28 days. Now I'm looking at it coming every 21 days. So, for a woman, this means she may start facing irregular cycles. And sometimes preceding the irregular cycles are shortened cycles. So, she may notice that her cycles were earlier 28 days, now they're every 21 days or every 22 days. So, these are very subtle early signs that she is coming towards the end of her reproductive phase. But during the perimenopause, it's not just the cycles that change, because we are also looking at, as you mentioned, you said, what hormones happen. So if you look at a typical cycle, we are looking at the first half being dominated mainly by estrogen, and then there being some ovulation. Let's say in a typical 28-day cycle, day 14 is when a woman will ovulate, and then progesterone takes over in the second half. Of course, there is still some estrogen there. It's basically preparing a woman for pregnancy. But now let's say she doesn't ovulate. So now she hasn't ovulated on day 14. The body or the ovary has not got the signal to produce progesterone. And now there is no progesterone. The lack of the rise and fall of progesterone makes her not get her period. So the period may be pushed down. For some, it may be early because of other hormonal changes. But now that progesterone also had some other functions. For some, it can be a little calming, and now that goes away. She may start complaining of a little bit of anxiety, some mood disorders. Just the fact that she is cycling all over the place can sometimes create other problems, which we can address later. But then gradually comes the estrogen decline, which also can happen simultaneously with the progesterone decline. And that estrogen decline will then create other symptoms, hot flashes, poor sleep. There are obviously mood disorders, there is urinary complaints, there are genital sexual complaints, lack of libido, dryness in the vagina, recurrent UTIs. So there's a entire list which I think most of us are aware of. But the important thing is estrogen, progesterone, the two big ones. And then finally comes testosterone. But testosterone, particularly if we look at data today, is not really linked with menopause. Testosterone decline seems to be more age dependent than linked to the event of menopause. So it may be picked up because she walked into the clinic for her menopause symptoms and we're talking to her and she's talking about libido, and one doesn't need to necessarily do a testosterone level, but the two graphs are quite separated out. And um, you know I, that's the other thing that we tend to want to find out. Oh, is it menopause or is it midlife? And it's a great research question, but at an individual level, does it matter to me if my symptoms are menopausal or related to midlife? Is Only makes the decision for hormone therapy. The rest of the stuff that I have to do for my health, for myself, it doesn't matter whether
Uh,
it's because of age or it's because of hormones.
sorry, I'm going to just sort of, I just want to sort of, just for the benefit of the audience, I want to just
Mhm.
segregate that. So, if we talk about estrogen loss, what would be the symptoms that we would generally attribute to estrogen loss, or progesterone loss? What would they be? Like, for example, would progesterone be sleep oriented or disorder in sleep versus estrogen is, and what would the testosterone loss create? Is there, are they sort of buckets, or are they sort of just crossing over, sorry, into each
A,
other?
l- a lot of them cross over. A lot of
Okay.
them cross over, especially mood changes. Hot flashes, typically estrogen loss. Joint muscle pain seems to be more estrogen loss. Bone density, etc. Now, that is something that the woman's not going to come to you with, but bone health mainly is estrogen loss. Um, but if you look at things like anxiety, you look at sleep, you look at mood, they are absolutely crisscross. So you're not really going to be able to identify. But a lot of women, when you correct or you add estrogen back, especially now, this becomes clear in women who've had a hysterectomy because they do not need that progestogen to be added. And we can talk about that later. But women with a hysterectomy do not need a progesterone or a progestogen. They can be put on estrogen alone. And estrogen alone can take care of most of their symptoms. And now that then makes it clear that should we only give estrogen to these women? Are these symptoms estrogen only dependent? Yeah, it's very hard to separate the two things. It's very hard, and I think there's a lot of individual variation as well, because we also know of a condition called PMDD, or premenstrual dysphoric disorder, which is basically PMS on a warpath. It's a very exaggerated PMS, which tends to happen more in the perimenopause. And
PMDD, you said PMDD. I'm
PMDD,
just sort of repeated
yes,
that, and you're saying this is like what we have when we have our period, like PMS, but exaggerated.
extremely exaggerated. Like women will categorically say, first 14, 15 days, I'm okay after a period. And then after that, there's a switch that turns off. I just become sad, depressed. I can't move myself. I start eating badly. I'm a different human being. They clearly say it. I'm a different human being. And the important thing here is that some of these women are sensitive to progesterone. And so progesterone sometimes becomes their enemy. So the progesterone switch comes on, and some of them don't do well. Some of them do well with it, but some of them actually are miserable just because progesterone did that to them. So it is, um, you know, it, again, it's very individualistic.
But can I
Sure.
ask a clarifying question? When you said progesterone came on and did that to them, means that they had a progesterone high and that did that to them, or they had an absolute withdrawal of progesterone and that did that to him?
For some women, actually, there are some there is some data suggesting add the progesterone, but for most of them, the management becomes using certain kinds of birth control pills, which basically takes that ovulation away, takes that progesterone away, and keeps them stable to that change in hormones. So for them, progesterone, actually they are progesterone sensitive. Any progesterone you put in them, they don't do well. So there will be that category of women as well. And I think that's important for us to. There are different types of progestrogens. Like you say, okay, don't take progesterone, take a different kind, take a different kind. So it's tailor made. You have to customize it, and the blanket cover that progesterone will help you sleep is something that women should not go back with. As I keep saying, we have women on hormone therapy who didn't sleep before hormone therapy and now sleeping really well. And we
Mm-hmm.
have women on hormone therapy who weren't sleeping before it and are still not sleeping. So,
Mm-hmm.
sleep is multifaceted, multifactorial. We cannot, progesterone's not the answer for every woman.
Got it. I want to sort of just go back and again talk a little bit more on the hormones part. What is the long term effect of the
Mm-hmm.
withdrawal of these hormones from your body? We know the short term is okay, so you have the symptoms. Maybe you take, maybe you have a solution for that. Maybe you take HRT, maybe you don't take HRT. Individually, your doctor advises. But what is the long term effect if you, let's assume, once you've had the withdrawal of these hormones? Is there any sort of, you know, anything dire that sort of affects your body, which we don't talk about too
Absolutely.
much?
Absolutely. And I think that is the most important question here, Roshni. I feel that's not usually given a lot of attention by women and doctors, by everyone. Being told that my menopause is over, like, I think that is the big question here. And what you're asking is directly relevant to this very frequently heard thing, mera to menopause khatam ho gaya. And that is something to really address, that it's never over because of what you mentioned, chronic deprivation of these hormones, especially estrogen. If you're going to look at the role of estrogen in the body, is not just getting us pregnant or producing eggs or supporting a pregnancy. The role of estrogen, we know there are estrogen receptors in practically every cell of the body, and so it has a role. Nature is extremely smart. It designed things evolutionarily. If it is redundant, it won't be there. So it is there in every cell for a very good reason, because it has a function. It does something there. But the big ones, if we look at as a bone health, because the bone is dependent on estrogen for turnover. And in
Mm-hmm.
the absence of estrogen, we're looking at a high risk of osteopenia, osteoporosis, fracture risk. And
Mm-hmm.
that's why the statistics that you hear often on the internet is 1 in 2 postmenopausal women will suffer from an osteoporotic fracture. Now, that is high. That means either you or me will have
Mm-hmm.
an osteoporotic fracture, right?
Mm-hmm. Mm-hmm.
And those statistics are scary, because without this scaffolding, we are nowhere. People think bone health can be addressed separately. I feel put bone health up there. It is the most important thing, because without the bone, if you fracture, you are not going to get up to walk, which means you are going to get sick everywhere, from your heart to mental health to your blood sugars to everything, right? It's just basically a lost game. And we have those statistics as well. We are looking at women who have a hip fracture, and within the first year, their mortality is extremely high. That means
Yeah.
you fracture your hip at 65, you'll probably be dead by, chances of dying by 66 are high. So, and besides that, it's the morbidity that it creates. So now I'm no longer functional, and I can't contribute to my family, to myself, and to look after myself. So that's a big one. I feel bone
Mm-hmm.
health is up there. We're looking at the
Mm-hmm.
heart. Look at heart attacks. You don't hear of a 35-year-old get a heart attack, or 40-year-old get a heart attack often, but female. But you hear of men getting heart attacks. That's because we
Mm-hmm.
are so beautifully protected by estrogen when we are younger. But
Mm-hmm.
come perimenopause, you see our LDLs, our bad cholesterols going up. We see our risk of heart attack going up, and very often being missed during that phase of opportunity, that we can do something about it. And then comes our risk suddenly from being male here, female here. during our reproductive age group, we're suddenly looking at them becoming even now. Estrogen no longer is protecting us against heart disease, against cardiovascular risk. So that is something that is important. The risk of Alzheimer's, the risk of diabetes. Yes, and these
Oh,
become more prominent, especially when you look at women who are who attain menopause prematurely.
so are we saying that women in anyone who goes into menopause, with this loss of estrogen, they is there any data like for diabetes? What is the increase in diabetes because of that loss of estrogen? What is the dementia risk? How much? I mean, we know this today, doctor. I mean, if just from studies or research that we've done, that I think it is 80% of dementia slash Alzheimer's patients are women.
It's
That
actually the figure is 2 in 3, so that's around 66-67%. 2 in 3 women
okay,
with Alzheimer, people with Alzheimer's are women. But the
okay,
important thing here is, we're not going to be able to, when you say separate out the data for menopause, it
yes,
means really long-term longitudinal studies. How do we do them? Right?
I
That
get
means
it.
we need tens of thousands of women who were followed up because aging is happening simultaneously. And then you look at different populations, right? Different populations, like typically the WHO has warned Indian women because they're not moving. Look at our data. Around 60% of us don't even meet the basic criteria of movement and exercise. So, how do we separate that cause from that of
From this,
menopause?
I
Yeah,
see, I
yeah,
see. But what we are saying is that we do know that the risk factor has significantly increased when you've had a loss of estrogen,
right.
heart health, bone health, dementia risk. Now, I want to also sort of add that you also said that there are women who have just stopped sleeping.
Yeah.
Uh, we know if you don't sleep, even if you're not in menopause, what sleep deprivation can do for even things like dementia and
Absolutely.
Alzheimer's. So we are talking about very high levels of risk for women for all these factors. Now you couple that with longevity for the next 30 years, 40 years of their life, which they never had earlier because they were just dying very young.
Yeah, yeah.
So what is the solution? I mean, is HRT so? Sh- sh- if I don't have symptoms, let's say I
Yeah,
don't have any of these hot flashes, I don't have any symptoms, no bloating, no
yeah,
nothing, nothing.
yeah,
Should
yeah,
I should I still be taking HRT because I want to prevent for this? And how long can I take HRT for? Like
yeah.
like like
Uh,
you said, like is it not 50 years? But I mean, how long do I take it for?
yeah, yeah. Yeah, Roshni, I think these are all, these are some great concerns, and this is something that I hear all the time, and it's my own question, right? For me, like, what am I going to do? What's my plan, right? So it's something that is, and none of these, everything that we record today. Trust me, in a year, you ask me the same questions, the answers may be quite different because we are
Because
looking
data.
at data come in every single day, right? The first 3 to 4 hours of my morning are actually just reading research because that's how rapidly data is coming out there. And to separate out good data from that is not that great, very hard to understand it, takes a lot of time. Very
Hmm.
easy for some statistic to be thrown out on Instagram, but understanding that statistic is really painstaking. So I feel like let's just break this up into many parts. Should every woman be on hormone therapy? No.
Hmm.
Every woman should know her risk of taking hormone therapy, but she should also understand her risk of not taking hormone therapy. And that I think is really important because, we think that indecisiveness is indecision is also a decision. So I think that is really important that, if you have understood the risks of taking it, and that scares you, understand the risks of not taking it. So I keep telling women, understand your why, Understand your why, and your why may change today to tomorrow to day after. But understand your why before you walk out of the doctor's clinic. Because if you are taking hormone therapy to lose weight, no, that's not a good reason. It doesn't help you lose weight. So understand your why, because that is something that you will stay true to. Because then if someone asks you outside, or a friend or a chacha or a chachi or someone says that, oh, you'll get cancer with it, then the bottom line is that you understood your statistics before you walked out of the doctor's office. So understand your why. Why should you take hormone therapy? So far, we have some approved indications. One of them are symptoms, especially vasomotor symptoms. What are the symptoms that hormone therapy may help? May. And I'm saying may because besides vasomotor symptoms, which are hot flashes and night sweats, all the other symptoms are what we call vague, because we'll never be able to pinpoint and say it's because of hormones that you're experiencing poor sleep, you're experiencing mood disorders, you're experiencing joint aches and muscle soreness, or sometimes we can say vaginal dryness and genitourinary syndrome of menopause. Something we can speak about, but these are the conditions where it may help with, and then you try it, and then you see whether your symptoms get better. If they do, it's trial and error.
But you said so. You're saying that understand your risks. I want to actually talk about that risk actually. Uh,
Yeah.
some people, it's good for some people, it's not good for. I want to go back and just quickly talk about. There was for the last 20 years, HRT was a high risk option, and not many women touched it because
Yeah.
of a study that was incorrect. Can you just briefly talk about what happened with the US FDA, the black box warning, and what has recently just happened? For 20 years, we didn't have much access. We didn't choose to have access to it, right? Because if you can just quickly
Right.
abbreviate that.
Sure, sure. So the WHI was a women's health initiative, and I just want to kind of make a little point here. It wasn't an incorrect study, it was just the data was interpreted poorly by the media. And I think that's
Hmm.
really important for us to understand. Again,
Okay.
like as I said when just a few seconds ago, that when we talk about research, it's very easy for someone to throw out a number, but what did that number really mean? Who were the subjects? What was studied? Very few people get into the nitty gritty, and by then the public has digested those numbers, and then we suffer the consequences for decades to come. And
Hmm.
so that's exactly what happened with the WHI. They basically tested there were two separate trials running in parallel, one in women without a uterus, one in women with a uterus. Now, let's just catch hold of the women with the uterus, because most of the women will have a uterus here.
Hmm.
And we will talk about the one without the uterus separately. But the women with a uterus were basically divided into two groups. One of them received the drug, which was the intervention, which was a combination of a certain kind of estrogen with a certain kind of synthetic progestin.
Progesterone.
So this was a combination, and they were put on this. The second group was on placebo, which is basically a sugar pill, or
Hmm.
basically a pill that doesn't have any active components. Now, when these women were followed up for around 5.5 years, what
Hmm.
they found was that there was a slightly higher risk of breast cancer in women who used this combination.
Hmm.
Now, when you look at that risk, the actual numbers in the study was women on the placebo or no intervention, or the what do you call it, the non-intervention group had 30 cancers out of 10,000 women. So if there
Hmm.
were 10,000 women being followed up for 1 year, in 1 year, 30 women developed cancer.
And
These
this is with the
women were not
placebo,
on
and this is
hormones.
placebo.
This is the
You're right.
placebo, yes.
Okay.
Now
Okay.
look at the women without, who were on the drug. If they were followed up for a year, 38 women out of 10,000 developed breast cancer.
Hmm.
So if we look at statistics in medicine or anywhere, there are two ways of comparing numbers. Simple
Hmm.
one, divide. Second one, subtract. So when you divide 38 by 30, you get 1.26. What does that mean? That is called a relative risk in statistics. A
I see.
relative risk, if converted into percentage, 1.26 means 26% higher risk of breast cancer,
I see.
right? Now I'm going to look at it with subtraction, what we call absolute risk. When you do 38 minus 30, I get 8 women per 10,000 women per year of use. And that gives me a risk or an absolute risk of 0.08%. Now, if I tell a woman you have a 26% higher risk of getting breast cancer, as opposed to a 0.08% increase of breast cancer per year of use, her decision will be very different. Because
Correct.
what were the absolute numbers? And that is really important. And the analogy I like to use while explaining is choosing a car while driving. You choose a brand A versus brand B. Your risk of dying of an accident in A, let's say, is 4 in 100,000. And in brand B is 5 in 100,000. If I actually divide and I give you relative risk, 5 divided by 4 is 1.25. So basically, you have a 25% higher risk of dying in car B than in car A. I'm going to go with car A, right?
Right.
But now, if I actually divide it, 5 minus 4 is 1 out of 100,000 will die,
Yes.
or even if you take it a million. So the bottom line is we have to understand absolute risk, we have to understand relative risk. They're very important. But when the media says you have a 26% chance, forget higher chance of dying or of getting breast cancer, then that's something that no woman is going to accept.
No, obviously not. So why has that warning been removed now? Because does science look at absolute risk more than relative, or why has that happened? Because the black box warning, as they call it, has today been removed from the U.S.
Yes. So the black box warning has been removed for many reasons, but one of them being that not all compounds are the same. More data has evolved over 20 years. This study was terminated in 2002, but there have been follow ups of women in 2013, 2017, 2020, even as one recently as 2025. So they've been following up the same bunch of women whose drugs were terminated, but now they're still following them up to see what's happening with their health. So more data has evolved. The 2020 paper made it pretty clear that even though there was a slightly higher risk of breast cancer mortality was not different in the two groups. So that was something to again, underscore and observe. Women in the estrogen alone group actually had a reduced risk of breast cancer and a reduced risk of dying of breast cancer. So women without a uterus, that group that I mentioned earlier, were only women without a uterus should take estrogen alone, and even some women without a uterus still need some progesterone for other reasons, but please do not take estrogen alone ever without speaking to your don't take any hormone without speaking to your provider. I just want to make that very clear.
This
But
is for
women in
regular
the
women,
estrogen
right?
alone group had
Or is this
this
women
is
with
for women without a
hysterectomies?
uterus
Right. Okay.
with
Hysterectomies.
hysterectomy. So women who
Okay.
do not have a uterus and are prescribed estrogen alone after being evaluated. So the bottom line is these women in that study did had a lower risk of breast cancer, and
Understood.
their risk of dying of breast cancer was also lower had they developed it. So I think the important thing here became, oh, it's actually the progestogen which is probably the problem. And the one used in this study was a synthetic one. And is that the one which can cause more trouble? So there have been more studies after that, not many so called randomized controlled trials, because the WHI made it unethical to have more RCTs exposing women to hormones which they demonstrated that could cause an increased risk. But the takeaway here is that data has evolved. It's been 25 years, 24 years now.
Mm-hmm.
Data has evolved, women have been followed up, other compounds have been used. So it's like saying, all kinds of alcohol are the same, all kinds of um, painkillers are the same. It's like grouping them together. So we cannot put all kinds of estrogen together, we cannot put all kinds of progestogens together. And a lot then went into removing the black box warning. It still does not mean it is safe for everyone, and I think that is the other thing that women need to understand. There's this feeling that the black box warning went away, so now it's safe for everyone. That's not true. It's
No,
still, the risks which are there still exist.
but I have a question. So you talked about the black box warning. Maybe if it's gone, so wasn't there also a certain age for the women that were in the group? Uh, from whatever little research we've done, I think those women were 60 years old, right?
Right.
Versus women who would be in their late 40s if they're going to early menopause, or even in their 50s. These were women who were all 60 years old and obviously had already gone through menopause. And this was
Right.
several years after. And isn't that a big factor also?
Well, it is, but it isn't the factor for, at least in my knowledge, for the black box warning, because the black box warning wasn't categorically removed for women in a certain age group. Yes, if you come back to the age-wise data distribution, you look at women who were 50 to 59, 60 to 69, and then 70 to 79 in the WHI. And
Hmm.
it seems like the maximum benefits lie with the women who were in the 50 to 59 age group.
Hmm.
So women in that group did not have a higher risk of stroke. That was also one of the problems with
Factors.
the WHI. Yes, so they did not have a statistically significant higher risk of stroke as compared to those women who were over the age of 70. So age-wise distribution definitely mattered. And then we look at why do most menopause societies say starting the benefits of hormone therapy usually outweigh the risks for women under the age of 60 and within 10 years of menopause. A lot of that the reason behind this statement lies on the age-wise distribution mentioned in the WHI. Plus, also there are some other studies which were done starting hormone therapy in the younger years, and that did show that these women did benefit more than those starting later on. So,
Later on.
yeah, but doesn't mean it again doesn't mean,
It's
and I
not a
like to say
blanket
this big.
anything. It's not
It's not a
blanket.
blanket anything, especially because I feel sometimes there are women over 60 and they deserve a complete conversation about their hormone therapy because they have missed the boat.
Hmm.
And no two 62-year-olds are the same, and no two 35-year-olds are the same. It's possible that at 35, you may have a contraindication to the use of hormone therapy. And it's possible that at 62, your benefits may still outweigh your risks. So I think everyone deserves a conversation. And that's something to keep in mind, that we shouldn't just let age decide what happens.
Right.
Listen to the woman, what she's saying, what is her quality of life, what is she willing to risk, and what are the benefits that she wants. I think we have to learn to listen.
Of course. Uh, just so, since we're talking about hormones, the bioidentical hormone, what was the birth of that? Was that because there was this black box warning that the bioidentical emerged? And how is it different?
Bioidentical really didn't emerge because of the black box warning. It started off. There are trials of micronized progesterone going back to 1996. The progesterone, which is the only progesterone which is bioidentical, so it didn't really start with any of this. So we were already researching estradiol, which is the bioidentical estrogen, and progesterone, which is the bioidentical progesterone. Studies were already beginning to creep up. So the point here is what is bioidentical, and let's just look at the the definition or the description firstly. Bioidentical refers only to chemical structure. So basically, it means bio, which is biologically identical to what I produce in my body or used to produce in my body. So we have different kinds of estrogen which are bioidentical. There are four of them, but the one that stands out the most is estradiol
Mm-hmm.
because that's the one commonly used in oral or transdermal, that is hormone estrogen, which is absorbed through the skin.
Mm-hmm.
Progesterone has only one bioidentical progesterone, which is called progesterone itself, and it is available as micronized progesterone, which is
Mm-hmm.
either used orally, vaginally, or rectally. So this is just knowing the definition.
Mm-hmm.
What bioidentical does not mean is it does not mean it's safer. It does not mean it's natural, and I think that is an important thing.
I think it's very important
Def-
because people think it's safer. People think it's more natural as well. But you're saying it's almost the same. But why did we need it? Why did we need bioidenticals?
I think we needed bioidenticals because we want to be as close to natural structure as possible. Natural structure, natural chemical structure. Not that it is. I think when I say natural, what I mean, I've stopped using the term natural because it's just used badly.
Misused.
And
Yes.
yeah, and if we look at women actually think that when we say bioidentical, it means it is there's a soybean or there's a yam and we take out the progesterone from it and then we use it. That's not true.
At all.
There are certain compounds which are found in soybeans and they are found in yam. Those compounds have to undergo 15 or more chemical reactions in a factory and
Mm-hmm.
then converted into 17 beta estradiol, which is available in your gel or your patch or whatever else that one is
Mm-hmm.
using, and or then converted to progesterone. That yam, that soy on its own, we don't have those enzymes in the human body to convert that chemical structure into the actual bioidentical hormone. So, I often see advertisements on many platforms of yam creams and other things like that. And they're no good.
So,
Or,
just for the benefit, bioidenticals are not any better than regular hormone replacement therapy. Uh,
no,
they
I
hold the
wouldn't say
same.
they're not better. I wouldn't say they're not better. There may be a safer profile if you're using it transdermally.
Mm-hmm.
So the reason why estrogen per se, if you're looking at now, the only bioidentical transdermal is oh, sorry, let me just rephrase that. The only transdermal estrogen that we have is bioidentical for hormone therapy. So
I see.
definitely safer because transdermal is safer. So I think we should look at the compounds separately. Like if you look at estradiol, yes, transdermal definitely has a better safety profile. Certain estradiol compared to which is available in MHD as compared to the one available in birth control pills, which is ethinyl estradiol. Yes, some studies have shown that it is safer on the more gentle on the coagulation profile. Very often we don't have head to head trials, so I don't like to use the term safer as a safety net because what is safe for you is most important. The second part is if you look at progesterone
Mm-hmm.
or different kinds of progestogens. The reason why I'm using these different terms is we have progestins, which are synthetic.
Mm-hmm.
We have progesterone, which is bioidentical. They all
Mm-hmm.
come under the roof of progestogens.
Mm-hmm.
They're all under the same roof. Their job in hormone therapy is to protect the uterine lining from developing endometrial cancer. That
Correct.
is their job, right? Now, that is where you have a choice. And if you choose progesterone, yes, some studies have shown they have a better breast profile, but these are only what we call longitudinal studies. We do not have what we call randomized controlled trials like the WHI, where women on the drug are compared with women on on a placebo, without any bias, and they're followed up. We don't have that. And therefore, to use the word safer as a it would be incorrect. Like, one could use it but also not use it. Like, I don't feel comfortable using it because we don't have that data. What we do have is that when we use micronized progesterone in longitudinal studies, they have not seen a higher risk of breast cancer up to 5 years of use as compared to the ones using synthetic progestins, which were used in the WHI. After 5 years, there has been an observation of a slightly increased risk, but it was still not as high as the small risk reported with the synthetic progestins in the WHI. So that risk was small to begin with. It seems that using micronized progesterone has an even smaller risk after using them for 5 years, but this is not based on randomized controlled trials. So that is something that then makes me uncomfortable in putting a blanket net and just saying it is um, safer.
No, but here's the thing. So I mean, just to for the audience purposes, right? It's some of this is very technical. There is a risk, yes, and you're saying there's a definition and a difference between the relative versus absolute. Obviously, every woman is different. She has to have come to you, or she goes to her doctor. She goes through her tests. What determines whether she should have it or not? Because there are also risks to her if she's not having it, right? The risk of that versus the risk of bone density, cardiovascular disease, dementia, and then she
Yeah.
has this risk on the other side. So, how is she how is she going to sort of navigate this?
Well, that's where informed,
Simplicity, just for
yeah, yeah,
simplicity for her to
yeah,
understand this.
absolutely. And I think that's a great question. And I feel that's where informed decisions and shared decision making comes in. Hormone therapy is not a decision alone to be made by your doctor. You have a very huge part to play in it. Because as a physician, the only thing I can do is I can explain risk to you, that yes, and your risk. So if I'm sitting with a woman and I'm looking at her with a DEXA scan, which is clearly saying she's got osteoporosis, but she's got no high risk for breast cancer. She's pretty low risk over there, and she's pretty healthy otherwise. The important thing for her to understand is she's got a much higher risk uh, of getting a fracture and her life going completely topsy turvy, as opposed to you know to, getting breast cancer. So that is one thing. If you're looking at someone else who's really fearful of breast cancer, and she's got multiple risk factors, and her risks are much higher in terms of hormone therapy than her benefits will ever be. Now my counseling is going to change accordingly, right? She needs to get that information. But
Hmm.
I think what women often seek is it safe? Nobody can say that. Nobody. And if anyone is saying that, you know what, that's just wrong.
I'm going to ask you another question because you're saying that, right? I agree. Which drug that we take is safe?
Yeah, tell me about it. Which
Allop- a-
vitamin do we
allop-
take?
I want to know which allopathic medicine that we take. I mean, from
Yeah.
any medicines that we are taking, which have all had clinical data, which of them are actually, would we say, are 100% safe?
So you don't have 100% safe drugs anywhere. You don't even have 100% supplements safe anywhere. So the point is,
Right.
like, there is a grading system. So there is a risk assessment system. Basically, you classify a drug as very risky, low risk, moderate risk, etc., depending on
Right.
how often these complications can occur.
Got it.
So 1 in 1,000 to 1 in 10,000 is counted as a rare risk. So that is something that one can look it up. It's there under the WHO, and one can look at what risk does it come into. Like, if I say 1 in 100, it's not a rare risk.
Hmm.
or 1 in 10 is not a rare risk. So the point is that I have to understand what that rare risk means and then take that call. Like if I tell a woman that your risk of getting breast cancer with every year of use increases by, 0.08%, but your risk of getting your 10-year risk of getting a hip fracture is 20%. That's a very high risk. But the bottom line is that at the bottom, the for her, this decision becomes quite clear. But there are lots of gray zones. And I think the important thing for women to understand is that understand your why. Understand your why. Because you'll
But
always question it,
and,
right?
understood. But if I was sort of classing that, so where since we are, I mean, I would talk about other drugs as well, but since we are talking about menopause and HRT potentially could be a solution and it may not be a solution for a lot of women.
Yeah.
If
Yeah.
just a regular girl and she doesn't have any cancer marker risks, etc., where is her risk? Is it like you said? Some of them are moderate, some of them are low. Where is it falling? Falling is her
We
risk
can't.
for HRT? You can't.
So for HRT, there is no real for HRT, or now we call it MHT. But the point is, there is no scale where we say, oh, her risk comes on this and her and that risk comes there. So the point is, for each woman, we would ideally want to calculate her FRAC score. That means what is her risk of fracturing? Is it low, moderate, high? The
Yeah.
second part is we would like to calculate her risk of developing breast cancer, which is there are certain models that one can follow. There's one Gale, there's one Tyrocusic. So that it has nothing to do with hormone therapy. It has to do with her risk of cancer. It would be good to assess her risk of cardiovascular disease. So that is something, again, that is a different calculator. But it does not tell us what will happen if we start hormone therapy for her. It is
Mm-hmm.
just to aid our clinical judgment that
Mm-hmm.
no, she's got very high risks for this. We should be counseling her about it. So that is an important guide for clinicians. It may or may not assist us in explaining it to her, because when you give a woman numbers, some do very well with those numbers, some get overwhelmed when you give them numbers.
Mm-hmm. Mm-hmm.
Yes, and it drives them away. And I think that's something that then sometimes, to simplify it, like, oh, osteoporosis, either you or me will have a fracture, and that becomes a simpler way of explaining it. That okay, there are 10 women in this room, maybe two of them will develop blah blah. So I think that's that's something that's important. But one very important thing, Roshni, is I think why women still opt for hormone therapy when they do is telling them that they're not getting married to it. Start it now. You'll observe how you're doing. You want, you stop it, right? So, but come back. Come back every year, because research will change. Maybe we'll have better things to offer. Yes. Or maybe you'll develop contraindications and you can't take it. But the bottom line is, please do keep coming back, because things are changing rapidly now. And we
Mm-hmm.
will have more things in the pipeline. So I think that's reassuring. Reassuring her that to choose hormone therapy for her quality of life is not a bad thing. And I feel like that is one thing, like, risk. But what about today? Risk still
Yeah.
means one in something.
Future.
It
The
does
future.
not mean, yeah, but risk does not mean absolute. Risk never means you will develop it. Risk means one out of these many women will get it. But it also means the remaining 900 and something will not get it.
Yeah.
So, yeah, yeah. But
Um,
there is no blanket that it is like, I feel every woman wants to hear that, including me. Tell me it's safe. Even I want to hear it.
I mean, I don't think any drug is safe.
Yeah,
And I
yeah.
think we take a lot of allopathic medicine,
Right,
but
right.
it's just different levels. What I wanted to just quickly do
Mm-hmm.
instead is go through what I would call a rapid fire round. These are questions asked by people on the internet.
Mm-hmm.
If we can just quickly answer
Sure.
those, that would be great. So the first question is, can I take HRT if I'm still getting periods? If I am in perimenopause but have not fully stopped.
Yes, you can.
Okay. Can HRT affect my fertility? If I'm in my early 40s and still want children, is HRT off the table?
Hormone therapy for symptoms does not stop one from ovulating, but if one is in their 40s, the best thing would be to focus on getting pregnant and using a different set of hormones rather than looking at hormone therapy on its own. So it requires more fertility counseling because there aren't too many years left.
Mhm. Will HRT make me gain weight or can it actually help me lose it?
Neither. You know, weight is still known to be dependent on a bunch of different factors, including mainly lifestyle. Some women do need other medication to help them lose weight, but MHT or hormone therapy is not a weight loss drug or weight gain drug.
Mhm. What are the real side effects of HRT? The ones a woman should genuinely watch for in the first 3 months?
So typically, what we hear about often are irregular spotting, bleeding, which can occur, some breast sensitivity, some nipple sensitivity. There can be some headaches for some women. There can be some changes in mood. These are the common ones that we see.
How long can I stay on HRT? Is there a point where I have to stop?
One has to stop when the risks outweigh the benefits. There is no hard stop, there is no age at which, or there is no fixed limit year wise to stop hormone therapy, but one does need individual risk assessment. So there are studies now of women using it way beyond 60, some even in their 80s. But the important thing is what else is going on in your body is what decides whether you continue it or not.
Mhm. Is it too late to start if I'm already 60 if I've already been postmenopausal for several years? I think you just answered that already.
Yes, yes.
Um, are there genuine alternatives to HRT that work, or is the herbal/supplement market mostly noise?
Supplements for me mean gaps in our nutrition that need to be filled. Supplements for me don't mean herbs which are in unphysiological doses encapsulated and being asked to ingest. So I think the important thing here to understand is that lifestyle definitely can do wonders. Personally, I was someone who did not use hormone therapy for 5 years post menopause. So I had a good 6 to 7 years of symptoms. Not really, actually, 2 years of symptoms, but then kind of plateaued off. So I've been without hormones for a long time and thrived without them as well.
Mhm.
Uh, After which I decided to use hormone therapy for other reasons. So the point here is I've done without, I've done with. Both are possible. The important thing here is again, if you're not going to take hormones, and even if you are, ideally, you should be working really hard on your lifestyle. But not using hormones for many years made me push every little stone there was towards lifestyle. So lots of women will choose not to take hormones either because of contraindications or because of their personal choice. It's
Mhm.
absolutely fine as long as you've made that decision well informed and are doing everything else. That's what's important.
Mhm. Um, if you had to leave Indian women with one sentence about menopause and HRT, the sentence you wish someone had said to you, what would it be?
Hmm. Someone had said to me, huh?
Early
Not
enough.
necessarily what I lift weights.
Thank you.
Lift weights, it'll save your life. Yeah.
Lift weights, it'll save your life. Um, and if this podcast had existed 20 years or 30 years ago,
Mhm.
how different do you think this landscape awareness for menopause would be today in India, especially?
I think our mothers would have done much better. I feel that was one generation that got that actually missed out because hormone therapy came in, showed them a glimpse, and then disappeared. And I feel that was a generation that really lost out. They could have that entire block that are currently who are currently undergoing fractures, are undergoing severe dryness, recurrent UTIs, many other problems. That whole generation could have benefited. Yeah. So at a population level, big loss for everyone.
Well, thank you so much, Dr. Sukhpreet. This was wonderful. I'd love to keep talking. I have more cards and more questions, but I know you are on a hard stop. So I am going to stop. But I am going to also
Thank you.
ask you if you might come back and finish this conversation sometime later.
Definitely, definitely. I think, Roshni, there is so much to talk about, and so many different factors. We haven't even spoken about vaginal
Yeah.
estrogen and,
Yes, yes, yes.
libido and
The
desire. I feel that is something that's just completely untouched in the very often not discussed in the Indian population.
No, no,
So,
absolutely. And they have
yeah,
very different consequences, right, by using it transdermally or exactly. So I would love to continue this conversation if possible sometime when you have a little bit more time.
definitely, definitely. I'd love that too.
Thank you so much. Thank you.
Thank you. Thank you.
If you took one thing from this conversation, take this. The HRT story most of us inherited is 20 years old. The science has moved, the fear hasn't caught up. There is a window, and it opens earlier than most of us were told. Starting the conversation in your 40s or 50s is not premature, it is the window. And if you've been told your brain fog is stress, your sleeplessness is anxiety, your aching joints are just age, and if you need answers, go to your doctor. And if they don't have them, find a better one. You're not crazy, you're not alone. It was menopause all along. Thank you. See you next episode.